Foundations of Maternal Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones. 7th edition. Chapter 24. High Risk Newborn, Acquired and Congenital Conditions. In addition to the high risk conditions related to gestational age discussed in Chapter 23, the newborn at risk may have acquired or congenital complications. Acquired conditions may be associated with prenatal complications or may occur at birth or shortly thereafter. Respiratory complications. Respiratory distress is one of the most common problems of the neonate. It may be caused by asphyxia before or during birth, disease of the respiratory system, and other conditions that affect the infant's ability to breathe. The nurse is responsible for identification and evaluation of respiratory status at birth and throughout the hospital stay. Asphyxia. Asphyxia is insufficient oxygen and excess carbon dioxide in the blood and tissues. It may occur in utero, at birth, or later, and results in ischemia to major organs. When asphyxia occurs at birth, it may be a continuation of asphyxia that began before birth, or the result of other factors such as preterm lungs with insufficient surfactant to function adequately. Maternal, placental, or fetal factors may be involved. Maternal factors include complications such as hypertension, infection, and drug use. Asphyxia in utero may be caused by placental conditions, such as placenta previa, placental abruption, or postmaturity. Cord problems, infection, premature birth, and multifetal gestation are among the fetal causes of asphyxia. Lack of oxygen transported to the cells lead to anaerobic metabolism and the production of lactic acid. Metabolic acidosis develops when inadequate bicarbonate is available to buffer the accumulating acids. Respiratory acidosis occurs as carbon dioxide accumulates. A high partial pressure of carbon dioxide occurs in arterial blood, PaCO2, and the partial pressure of oxygen, PO2. The pH and bicarbonate are low. Vasoconstriction caused by low oxygen decreases blood flow to all organs except the brain, myocardium, and adrenal glands. The ductus arteriosus and foramen ovale may remain open because of the low oxygen in the blood, high resistance to blood flow through constricted pulmonary vessels, and elevated pressure on the right side of the heart. Therefore, even circulating blood remains low in oxygen concentration. Progression toward brain injury and death is rapid unless intervention is prompt. Problems may continue even if the infant survives. Pulmonary ischemia interferes with the ability to produce surfactant, increasing the risk for respiratory distress syndrome. Intrauterine stress may lead to passage of meconium and meconium aspiration syndrome. Manifestations. When asphyxia occurs after birth, rapid respirations are followed by cessation of respirations, primary apnea, and a rapid fall in heart rate. Stimulation, alone or with oxygen, may restart respirations. If asphyxia continues without intervention, gasping respirations may resume weakly until the infant enters a period of secondary apnea. In secondary apnea, the oxygen levels in blood continue to decrease. The infant loses consciousness, and stimulation is ineffective. Resuscitative measures should be initiated immediately to prevent permanent injury to the brain or death. Asphyxia seen at birth may be a continuation of asphyxia that began before or during birth. Therefore, it is essential to begin resuscitation without delay. Infants at risk. Complications that occur during pregnancy, labor, or birth increase the infant's risk for asphyxia. In addition, if the expectant mother receives narcotics for analgesia shortly before birth, the infant's central nervous system, CNS, may be too depressed at birth to allow adequate spontaneous breathing. Neonatal resuscitation. Although most newborns have no difficulty with breathing at birth, up to 10% require some help to begin respirations and 1% require extensive resuscitative measures. Therefore, all personnel involved in deliveries should know how to perform resuscitative measures. Courses in neonatal resuscitation are usually required of all staff members working with newborns, and many agencies expect these skills to be updated every 1 to 2 years. Chest compressions and medications are rarely needed during resuscitation. Nurses should be prepared for situations in which asphyxia may develop. Effective ventilation is the most important element in resuscitation. Equipment should be readily available and functioning properly at all times, so there is no delay in starting resuscitation. Nurses begin resuscitation measures as necessary and assist the physician or nurse practitioner with intubation, insertion of umbilical vein catheters, and administration of medications. Maintenance of thermoregulation is very important throughout the care. A warming pad may be placed under linens in the radiant warmer to provide extra heat. Infants less than 29 weeks of gestation may be placed in a polyethylene bag up to the neck before they are dried to reduce heat loss from evaporation. The bag also reduces stress from handling during drying. It is important to prevent hyperthermia when the bag is used with a chemical warming pad. Some infants develop hypoxic ischemic encephalopathy after asphyxia. Therapeutic hypothermia has been used to improve neurologic outcomes for these infants. Infants should be 36 or more weeks of gestation, have evidence of an acute perinatal hypoxic ischemic event, and be in a facility where the treatment can be initiated within 6 hours of birth. Once the infant is stabilized, the nurse continues to assess for changes. Infants with asphyxia often have other complications such as hypoglycemia, feeding and thermoregulation problems, seizures, hypotension, pulmonary hypertension, metabolic acidosis, renal problems, and fluid and electrolyte imbalances. They need close monitoring and often need intensive nursing care. Communication with the parents is a vital nursing function. They will be confused and frightened and will need explanation and realistic reassurance. Parents often need continued support after the crisis to talk about their fears and concerns. Transient tachypnea of the newborn, retained lung fluid. Infants who experience transient tachypnea of the newborn, TTN, develop rapid respiration soon after birth from inadequate absorption of fetal lung fluid. Although the condition usually resolves within 24 to 48 hours, it is the most common respiratory cause of admission to a neonatal intensive care unit. Risk factors include cesarean birth with or without labor, macrosomia, multiple gestation, excessive maternal sedation, prolonged or precipitous labor, male gender, and maternal diabetes or asthma. Mild immaturity or surfactant production also may be a factor. Infants are usually term or late preterm, although some may be preterm. Cause. Although the exact cause of TTN is unknown, it is thought to result from a delay in absorption of fetal lung fluid by the pulmonary capillaries and lymph vessels. This leads to decreased lung compliance and air trapping and produces signs similar to those of RDS. Manifestations. In TTN, tachypnea develops within 6 hours of birth. Grunting, retractions, nasal flaring, and mild cyanosis also are present. Chest radiography demonstrates hyperinflation, hilar streaking that shows engorged lymphatics, and the presence of fluid in the fissures between the lobes and in the pleural space. Therapeutic management. Treatment is supportive and may include oxygen for cyanosis. Gavage feeding may be given when the respiratory rate is high to prevent aspiration and conserve energy. Because the signs are similar to those of RDS and sepsis, the infant is observed for these complications. Antibiotics may be given until sepsis is ruled out. Continuous positive airway pressure is rarely needed. Nursing considerations. The nurse may be the first person to see signs of TTN, especially if they are not apparent at birth. After identifying these signs, the nurse notifies the provider and carries out treatment. General nursing care is similar to that of the respiratory care of the preterm infant. Meconium aspiration syndrome. Meconium staining of amniotic fluid occurs in 10 to 15% of births. Meconium aspiration syndrome, MAS, is a condition in which there is obstruction, chemical pneumonitis, and air trapping caused by meconium in the lungs. It develops in 5% of those infants. The condition occurs most often in infants who are post-term, small for gestational age, SGA, and compromised before birth by placental insufficiency with decreased amniotic fluid and cord compression. Causes. Although a normal fetus may pass meconium, MAS occurs most often when hypoxia causes increased peristalsis of the intestines and relaxation of the anal sphincter before or during labor. MAS develops when meconium in the amniotic fluid enters the lungs during fetal life or at birth. It may be drawn into the lungs if gasping movements occur in utero as a result of asphyxia and acidosis, or the meconium in the upper airways may be pulled deep into the respiratory passages when the infant takes the first breaths after birth. Obstruction of the airways may be complete or partial. Atelectasis may result if small airways are completely obstructed. In partial obstruction, air can enter but not escape from the alveoli. During inhalation, the bronchioles expand slightly as air flows into them past the meconium. During exhalation, the passages constrict and meconium blocks the movement of air out of the lungs. This ball valve mechanism results in air trapping. The overdistended alveoli may develop an air leak with escape of air into the pleural cavity, pneumothorax, or mediastinum, pneumomediastinum. Surfactant production may be inhibited, increasing respiratory distress. In addition, meconium is irritating to lung tissue and causes an inflammatory reaction and chemical pneumonitis. Severe MAS develops in only a small number of newborns with meconium below the vocal cords. The addition of meconium to lungs injured by asphyxia may increase the severity of the condition. Injury from asphyxia interferes with clearing of lung fluid and production of surfactant and causes pulmonary vasoconstriction that can result in return to fetal circulation patterns. MAS may lead to persistent pulmonary hypertension. Manifestations. If meconium in the amniotic fluid is minimal, respiratory problems usually do not develop. However, more meconium may cause serious respiratory pathologic issues. Signs of mild to severe respiratory distress are present at birth, with tachypnea, cyanosis, retractions, nasal flaring, grunting, crackles, and in severe cases, a barrel-shaped chest from hyperinflation. Radiography shows patchy infiltrates, atelectasis, consolidation, and hyperexpansion from air trapping. The infant's nails, skin, and umbilical cord may be stained yellow-green. Therapeutic management. Suctioning the infant's secretions as soon as the head is born has not been found to reduce the incidence of MAS. At birth, the vigorous infant, who has a heart rate more than 100 beats per minute, spontaneous respirations, and good muscle tone, does not need special suctioning and receives routine care. Infants with depressed respirations and muscle tone should be moved to a radiant warmer and suctioned with a bulb syringe. If the infant is not breathing or has a heart rate below 100 bpm after opening the airway, suctioning, and being dried and stimulated, positive pressure ventilation is required. Infants may need only warmed humidified oxygen, or extensive respiratory support with mechanical ventilation may be required. High-frequency ventilation may be used. Surfactant lavage has been used in severe cases, but is controversial. Ongoing management consists of supportive care to meet the problems presented. Infants with severe MAS who do not respond to conventional treatment may benefit from extracorporeal membrane oxygenation, ECMO. ECMO, which is available in some hospitals, oxygenates blood while bypassing the lungs, much like heart-lung machines used during heart surgery. It allows the infant's lungs to rest temporarily and recover. Nursing considerations. When meconium is noted in the amniotic fluid during labor, the nurse notifies the primary provider so the delivery care can be adapted as necessary. Nurses from the NICU and neonatologist may be present for the birth. The nurse ensures that equipment such as oxygen and suction devices are functioning properly and assists with care at birth. After the infant's birth, nursing care is adapted to the problems presented. Although meconium is sterile, lung injury promotes the growth of bacteria. Infants should be closely observed for infection, which may further complicate the condition. Nursing attention to thermoregulation and decreased stimulation is important. Persistent pulmonary hypertension of the newborn. PPHN is a condition in which pulmonary vasoconstriction occurs after birth and elevates vascular resistance of the lungs. Normal changes to neonatal circulation are impaired as a result. For this reason, the condition is called persistent fetal circulation. Causes. PPHN occurs most often in infants who are term or post-term. The cause may be abnormal lung development or maternal use of non-steroidal anti-inflammatory drugs, NSAIDs, or selective serotonin reuptake inhibitors, SSRIs. Or it may be unknown. It is often associated with hypoxemia and acidosis from conditions such as asphyxia, MAS, sepsis, polycythemia, diaphragmatic hernia, and RDS. Inadequate oxygenation results in vasoconstriction instead of the normal dilation of the pulmonary artery and small pulmonary vessels. which causes increased vascular resistance in the lungs. The elevated pulmonary vascular resistance causes a rise in pressure on the right side of the heart. This results in a right-to-left shunt of unoxygenated blood that flows through the foramen ovale. In addition, unoxygenated blood from the pulmonary artery flows through the ductus arteriosus to the aorta. Thus, blood bypasses the lungs, as occurs during fetal circulation. Metabolic acidosis causes pulmonary vasoconstriction, making the condition even worse. Manifestations. Infants with PPHN develop signs within the first 12 hours after birth. Tachypnea, respiratory distress, and progressive cyanosis often become worse with handling. Oxygen saturation and partial pressure of oxygen in arterial blood, PaO2, are decreased. PaCO2 is increased, and acidosis is present. Other signs may result from associated conditions. An echocardiogram demonstrates right-to-left shunting through the foramen ovale and ductus arteriosus. Therapeutic management. Management involves treating the underlying cause of poor oxygenation and relieving pulmonary vasoconstriction. Arterial pH may be increased with respiratory therapy and drug therapy to cause pulmonary vasodilation. Sedation, high-frequency ventilation, and surfactant therapy may be necessary. Inhaled nitric oxide may be given to dilate pulmonary vessels. ECMO therapy may be life-saving if conventional therapies are unsuccessful. Nursing considerations. Nursing care is similar to care of other infants with severe respiratory disease. Because infants become hypoxic with activity and other stimuli, handling and noise are kept to a minimum. Cold stress increases the metabolic rate and need for oxygen and causes additional pulmonary vasoconstriction. Therefore, the nurse should pay particular attention to maintaining the infant's temperature. Assessment for hypoglycemia, hypocalcemia, anemia, and metabolic acidosis is important. Hyperbilirubinemia, pathologic jaundice. Jaundice is a common concern in the care of neonates. Conjugation of bilirubin and physiologic jaundice are discussed in Chapter 19 and 20. This discussion focuses on non-physiologic or pathologic jaundice. When the total serum bilirubin (TSB) level is greater than 5 to 6 milligrams per deciliter, jaundice appears. Jaundice is considered abnormal or non-physiologic when the TSB rises more rapidly into a higher level than is expected or stays elevated for longer than normal. Charts showing the expected rise and fall of bilirubin, according to the age of the infant in hours, are used to determine the degree of risk and which infants need treatment for rising TSB level. Non-physiologic jaundice may be seen in the first 24 hours of life. It is a concern because it may lead to bilirubin encephalopathy, the acute manifestation of bilirubin toxicity. This may lead to kernicterus, the chronic and permanent result of bilirubin toxicity. In this condition, bilirubin deposits cause yellowish staining of the brain, especially the basal ganglia, cerebellum, brainstem, and hippocampus. It is more likely to occur in infants who have suffered hypoxemia, respiratory acidosis, infection, dehydration, or other injury that impairs the blood-brain barrier and allows unconjugated bilirubin to enter the brain. Although bilirubin encephalopathy and kernicterus are rare today because of improved treatment measures, the mortality and morbidity rates among affected infants are high. Those who survive may suffer from cerebral palsy, cognitive impairment, hearing loss, or more subtle long-term neurologic and developmental problems. The exact level at which bilirubin encephalopathy develops is not known. The toxic level may not be the same for all infants. It occurs at lower TSB levels and is more severe in infants who have complications, who are preterm or late preterm, or who have low birth weight than in full-term healthy infants. Causes. The most common cause of pathologic jaundice is hemolytic disease of the newborn, from incompatibility between the blood of the mother and that of the fetus. The best known cause is Rh incompatibility, in which the Rh negative mother forms antibodies when blood from an Rh positive fetus enters her circulation. Antibodies may have developed during a previous pregnancy or after injury, abortion, amniocentesis, or a transfusion of Rh positive blood. The antibodies cross the placenta, attach to fetal red blood cells, and destroy them. The result is erythroblastosis fetalis, agglutination and hemolysis of fetal erythrocytes from maternal fetal blood incompatibility. Infants with erythroblastosis fetalis are anemic from destruction of RBCs. Severely affected infants may develop hydrops fetalis, a severe anemia that results in heart failure and generalized edema. Intrauterine fetal transfusions may be given. After birth, phototherapy and exchange transfusions are used to prevent kernicterus. Use of Rho-D immune globulin (RhoGAM) to prevent the mother from forming antibodies against Rh-positive blood has greatly decreased the incidence of erythroblastosis fetalis. ABO incompatibility also causes pathologic jaundice. Mothers with type O blood have natural antibodies to type A and B blood. The antibodies cross the placenta and cause hemolysis of fetal RBCs. However, the destruction is much less severe than with Rh incompatibility and causes milder signs. This is because most of the antibodies are immunoglobulin M, IgM, which does not cross the placenta. Some of the antibodies are IgG, which does cross the placenta and can cause RBC destruction, but usually at a lower rate. Other causes of non-physiologic jaundice include infection, hypothyroidism, glucuronal transferase deficiency, polycythemia, glucose 6-phosphate dehydrogenase deficiency, and biliary atresia. Infants of diabetic mothers are more likely to develop non-physiologic jaundice, especially if they have macrosomia. Any condition that causes destruction of erythrocytes or impairment of the liver may result in elevated bilirubin levels. Therapeutic management. The focus of therapeutic management is prevention of bilirubin encephalopathy and kernicterus. The cause is determined by history and diagnostic tests to identify infections or blood abnormalities. During pregnancy, an Rh-negative mother will have blood drawn for an indirect Coombs test to identify the presence of antibodies against fetal blood. If the antibodies are present, additional testing may be performed to evaluate fetal status. When an infant is jaundiced, the infant's blood type and a direct Coombs test are performed. A positive Coombs test indicates the antibodies from the mother have attached to the infant's RBCs. TSB levels are monitored closely to detect changes that indicate treatment should be initiated or changed. The healthcare provider considers the bilirubin levels as well as other factors, such as gestational age and presence of other risk factors, to determine whether therapy is appropriate for an individual infant. Nurses assess infants for changes in jaundice. However, visual inspection for jaundice is not an accurate way of determining actual bilirubin levels. Because taking blood samples for TSB measurement is painful and expensive, other non-invasive tests may be used. Transcutaneous bilirubinometers are handheld devices that allow screening of transcutaneous bilirubin (TCB) level. When the sensor on the device is placed against the infant's skin, the amount of bilirubin in the tissues is measured. The non-invasive test allows frequent estimates of the TSB level without discomfort to the infant. However, it may not be accurate in preterm infants, in infants receiving phototherapy, or if TSB levels are above 15 milligrams per deciliter. Phototherapy. Phototherapy is the most common treatment for jaundice and involves placing the infant under special fluorescent lights. During phototherapy, bilirubin in the skin absorbs the light and changes into water-soluble products, the most important of which is lumirubin. These products do not require conjugation by the liver and can be excreted in bile and urine. Because preterm infants are more vulnerable to bilirubin toxicity, phototherapy is begun at lower TSB levels than for full-term infants. Phototherapy can be delivered in several ways. A bank of fluorescent lamps, or Billy lights, can be placed over the infant who is in an incubator or under a radiant warmer to maintain heat or in an open crib. The infant wears only a diaper to ensure maximal exposure of the skin to the lights. The diaper is removed if the TSB is becoming dangerously high. The eyes are closed and patches placed over them to protect them from injury. The lights are placed over the infant at a distance determined by the type of bulb used. More than one bank of lights may be used if the bilirubin level is very high. Bilirubin levels are checked frequently to determine the effectiveness of treatment and when it can be discontinued. Other options for phototherapy include light-emitting diodes, LEDs, halogen lamps, and fiber optic phototherapy blankets. As with fluorescent lights, the LED device is placed over the infant. It is long-lasting, does not generate excessive heat, and decreases insensible water loss. The halogen spotlight is used alone or with other lamps. The infant can be swaddled with fiber optic phototherapy blanket against the skin and does not require patches over the eyes. With the blanket, the mother may hold the infant without interfering with therapy. However, the blanket is not as effective alone as with other methods. To increase its effectiveness, the blanket may be placed under the infant when phototherapy lights are used. A billy bed is also available with the phototherapy device built into the part of the bed that lies under the infant. The side effects of phototherapy include frequent loose green stools that result from increased bile flow and peristalsis. This causes more rapid excretion of the bilirubin but may be damaging to the skin and result in fluid loss. A 25% increase in fluid intake is needed during phototherapy. A macular skin rash may occur in some infants. Bronze baby syndrome, a grayish-brown discoloration of the skin and urine, occurs in some infants with cholestatic jaundice. The rash and color changes disappear gradually when phototherapy is completed. When phototherapy is discontinued, a rebound TSB level increase of 1 to 2 milligrams per deciliter is normal. Therefore, the TSB should be monitored for at least 24 hours to see that it does not become excessively high. Explain the expected elevation to parents and that the healthcare provider may order additional blood tests after discharge. Exchange transfusions. Exchange transfusions are seldom necessary but are performed when phototherapy cannot reduce dangerously high bilirubin levels quickly enough. This treatment removes maternal antibodies, unconjugated bilirubin, and antibody-coated sensitized RBCs. It provides fresh albumin with binding sites for bilirubin and helps correct severe anemia. When an immediate transfusion is needed for Rh incompatibility, type O Rh negative blood cross-matched against the mother and infant is used. In ABO incompatibility, packed RBCs with type AB plasma are used so that there is no anti-A or anti-B antibodies present to destroy the erythrocytes. Procedure. During the exchange transfusion, small portions of blood are removed from the infant and replaced with an equal amount of donor blood. Because the donor blood mixes with the infant's blood, approximately twice the infant's blood volume is administered. At the end of the transfusion, approximately 85 to 90% of the infant's RBCs will have been replaced and the bilirubin level reduced by 50% or less. When the bilirubin level in blood decreases, bilirubin from tissues moves into plasma. This may increase the level of bilirubin in the blood to 60% of the pre-exchange level. The rebound elevation of bilirubin level may necessitate repeat transfusions, but phototherapy is generally adequate to resolve it. Complications. Complications that may occur from exchange transfusions include electrolyte and acid-base imbalance, hypocalcemia, hypomagnesemia, hypocalcemia, hyperkalemia, infection, cardiac dysrhythmias, necrotizing enterocolitis, bleeding, thrombosis, thrombocytopenia, and air embolism. Samples of blood are analyzed for a complete blood cell count, bilirubin and calcium levels, and other tests as needed before and after the exchange. Role of the nurse. The nurse's role during exchange transfusion is to prepare equipment, assess the infant during and after the procedure, and keep accurate records. A cardiac monitor is attached to the infant, and warmth is provided by a radiant heater. The nurse also should clarify any misunderstandings that the parents may have about the treatment and help allay their anxiety. Application of the nursing process. Hyperbilirubinemia. Assessment. Assess the level of jaundice at least every 8 hours by blanching the skin, pressing the skin over a bony prominence, to see the color in the area before blood returns. Evaluate the skin color in good light with phototherapy lights turned off because they distort the skin color. In infants with dark skin, assess the color of the palate and mucous membranes of the mouth and the conjunctivae. Determine the areas of the body affected by jaundice and document carefully to use for comparison during future assessments. Jaundice begins at the head and moves down the body as the bilirubin level rises. Monitor the TSB and TCB levels for change because visualization of jaundice is a subjective assessment and the color in the skin may be affected by phototherapy. Assess for risk factors that might further increase bilirubin levels. Note temperature fluctuations, hypoglycemia, and infection. Determine the infant's oral intake and number of stools. Identification of patient problems. In addition to the possibility of increasing bilirubin levels, the infant receiving phototherapy is at risk for associated problems. These potential problems include injury caused by the light, temperature instability, changes in fluid and nutrition status, and damage to the retina. Planning expected outcomes. Nurses can do many things to prevent situations that might cause further rises in bilirubin. They should also protect the infant from injury caused by the light during phototherapy. The expected outcome for this diagnosis is that the infant will have no injury resulting from increased bilirubin levels or exposure of the skin or eyes to phototherapy lights. Interventions. Interventions are designed to prevent situations that might cause injury to the infant from rising bilirubin levels or effects of treatment. Maintaining a neutral thermal environment. Prevent situations such as cold stress or hypoglycemia, which could result in increased fatty acids in blood caused by acidosis. Acidosis would decrease the availability of albumin binding sites for unconjugated bilirubin. Prevent cold stress at birth and during all care by maintaining the infant in a neutral thermal environment. Check the infant's axillary temperature every 2 to 4 hours to identify an early decrease before it becomes a problem. Dress the infant in warmed clothes and blankets on removal from phototherapy lights. Prevent elevation of the infant's temperature from exposure to heat of the bili lights. Position the lights according to the manufacturer's guidelines to prevent overheating. Use a skin probe when the infant is in an incubator or radiant warmer to maintain the appropriate environmental temperature and monitor the settings to be sure they are correct for the infant's needs. Providing optimal nutrition. Ensure the infant receives feedings as prescribed. Breastfeeding should not be stopped because the infant is receiving phototherapy. Provide extra support in teaching to breastfeeding mothers having difficulty. Frequent feedings prevent hypoglycemia, provide protein to maintain the albumin levels in the blood, and promote GI motility and prompt removal of bilirubin from the intestines. Avoid offering water because the infant may take less milk, which is more effective in promoting stooling and removal of bilirubin from the intestines. If breastfeeding must be supplemented, use formula instead of water. Weigh the infant at least daily and monitor intake and output to identify dehydration early and intervene appropriately. Protecting the eyes. Provide patches to protect the eyes from retinal damage from the phototherapy lights. Close the infant's eyes before placing the patches to avoid abrasions to the cornea. Check the position of the patches at least every hour. Infants often wiggle enough to push the patches above or below the eyes, leaving them exposed. The edges of the patches can press too hard on the eyes or compress the nose and interfere with breathing. Turn off the lights and observe for skin irritation around or under the patches at least every 4 hours. Explain to the parents that it is normal for the yellow color under the patches to be deeper than in areas that have been exposed to the lights. Enhancing response to therapy. Position the lights the proper distance from the infant. Lights that are too close may burn the skin. Lights too far away from the infant will not be effective in reducing jaundice. Halogen lights should be placed farther away from the infant than other lights to prevent burning. Follow the manufacturer's instructions about light placement. Although phototherapy increases insensible water loss from the skin, avoid the use of creams or lotions on the infant's skin that might cause burning. Use a light meter to check the level of irradiance energy output. To be sure the apparatus is functioning appropriately and to determine whether the bulbs need to be replaced. Check laboratory reports of TSB levels to determine the effectiveness of treatment and when it can be discontinued. Expose as much skin as possible to the light. Remove all of the infant's clothing except a diaper. Turn the infant frequently to expose all areas evenly and prevent irritation of the skin from lack of position change. If a fiber optic blanket is used, check the position of the blanket frequently. Infants sometimes need to be repositioned so that the blanket remains in contact with the skin. Detecting complications. Observe for other complications. Although bilirubin encephalopathy is rare today, monitor for signs that indicate its presence. These include lethargy, increased or decreased muscle tone, poor feeding, decreased or absent Moro reflex, high-pitched cry, opisthotonos, and seizures. Definition of opisthotonos from Google. Spasm of the muscles causing backward arching of the head, neck, and spine. Note the presence of rashes or changes in the color of the skin. Inform parents that they are not harmful and will disappear when phototherapy is discontinued. Teaching parents. Explain care to parents who may be frightened to see their infant in an incubator with the infant's eyes covered. Explaining the causes of jaundice and the purpose of phototherapy will decrease their worry. Removing the infant from phototherapy for feeding and interaction with the parents for periods up to an hour at a time does not significantly decrease the effectiveness of phototherapy. In addition, allowing parents to hold their baby increases their opportunity for attachment. Explain the importance of minimizing further interruptions to phototherapy. When the infant is discharged, give the parents written and verbal information about jaundice. Teach them how to assess for further jaundice, signs of complications, and when to call the healthcare provider. Emphasize the need to keep follow-up laboratory work and visits to the healthcare provider so any increases in jaundice or other problems can be identified and treated early. Explain that most infants have no further problem with jaundice. Although sunlight is known to reduce bilirubin level, caution the parents against putting the infant in direct sunlight. The infant might be sunburned or have temperature instability and is exposed to unnecessary ultraviolet light from the sun. Evaluation. No signs of injury should be present. The infant's eyes will not have been exposed to the phototherapy lights, and the skin should not be harmed. Laboratory reports should show a steady decrease of serum bilirubin level. Infection. Nurses should be constantly alert for signs of infection in newborns. As many as 10% of infants develop infections during the first month of life. Transmission of infection. Newborns can acquire infections before, during, or after birth. Vertical infection is acquired before or during birth from the mother. Organisms such as those causing rubella, cytomegalovirus infection, syphilis, HIV, and toxoplasmosis may pass across the placenta and cause infection during pregnancy. During labor and birth, organisms in the vagina such as group B streptococcus GBS, herpes, and hepatitis may enter the uterus after rupture of membranes or infect the infant during passage through the birth canal. Horizontal infection occurs after birth, acquired from hospital staff members or from contaminated equipment, healthcare-associated infections, or from family members or visitors. An example is staphylococcal infections associated with central venous catheters. Some of the most common infections and their effects on the neonate are listed in Table 24.1. Other infections are discussed in Chapter 10. Sepsis neonatorum. Infection that occurs during or after birth may result in sepsis neonatorum, a systemic infection from bacteria in the bloodstream. Newborns are particularly susceptible to sepsis because their immune systems are immature and they react more slowly to invasion by organisms. Newborns and especially preterm infants have fewer antibodies and are unable to localize infection as well as older children. This inability allows the infection to spread easily from one organ to another. In addition, the blood-brain barrier is less effective in preventing the entrance of organisms, and CNS infection may result. Causes. Common causative agents of neonatal sepsis include bacteria such as GBS, Escherichia coli, Coagulase negative Staphylococcus, Staphylococcus aureus, and Haemophilus influenzae, and fungi such as Candida albicans. Sepsis may be divided into early onset and late onset sepsis, according to when signs of disease begin. Early onset sepsis is acquired during birth, often from complications of labor such as prolonged rupture of membranes, prolonged labor, or chorioamnionitis (III). Infants show signs within the first 3 days of life. It is a rapidly progressive multisystem illness with high mortality and morbidity rates. Pneumonia and meningitis are commonly present. Late onset sepsis is most common after the first week of life. It is acquired during or after birth, before or after hospital discharge. It is usually a localized infection such as meningitis, and serious long-term effects are common. Therapeutic management. Diagnostic testing. Neonatal sepsis may be confused with other illnesses. For example, GBS pneumonia has the same initial symptoms as RDS. Diagnostic testing helps identify sepsis and the organisms responsible. A CBC count with differential may show decreased total neutrophils, increased bands, a form of immature neutrophils, an increased ratio of immature neutrophils to total neutrophils, and decreased platelets. Elevated levels of leukocytes are normal in newborns. However, a sudden rise or fall in leukocyte levels compared with previous results is abnormal. The presence of elevated IgM levels in cord blood or shortly after birth indicates that infection was acquired in utero because this immunoglobulin does not cross the placenta. It often indicates transplacental infection. The C-reactive protein, CRP level, a sign of an inflammatory process, may be elevated. Serial tests of CRP are often performed to check for rise and then fall as infection improves. Cultures of blood, urine, and any skin lesions, and cerebrospinal fluid may be obtained. Cultures of the nasopharynx, umbilical cord, and gastric aspirate usually show colonization with organisms but not infection. Chest radiography helps differentiate between RDS and sepsis. Blood glucose levels should be checked because they may be unstable, high or low, in sepsis. Infants who develop signs of infection are treated with broad-spectrum antibiotics given intravenously until culture and sensitivity results are available. Continued antibiotic therapy is based on culture results. Commonly used antibiotics include ampicillin, aminoglycoside, and cephalosporins. Vancomycin also may be used. Other care is supportive to meet the infant's specific needs. The infant may require oxygen or mechanical ventilation. Fluid balance maintenance and monitoring of the blood pressure and hourly urine output are important. Shock, hypoglycemia or hyperglycemia, electrolyte imbalances, and problems in temperature regulation are potential complications. Nursing considerations. Assessment. Risk factors. The nurse should identify infants at risk for infection. Prematurity and low birth weight are the most important risk factors. Infants of mothers who have rupture of membranes longer than 12 to 18 hours also have an increased risk for infection. Other risk factors for sepsis include prolonged or precipitous labor, signs of maternal infection before or during labor, chorioamnionitis, also known as III, and foul-smelling amniotic fluid. The nurse should identify women known to be GBS positive and those who show signs of infection so they can be treated with antibiotics during labor to reduce risk to the infant. Every infant in the NICU is at risk for healthcare-associated infections. These infants have complications or conditions such as prematurity that make them more susceptible to infection. The risk for infection increases as gestational age and birth weight decrease. Preterm infants have not received maternal antibodies that help protect them from infection. In addition, they sometimes spend prolonged periods in the NICU, where they are exposed to many invasive procedures such as use of IV catheters and endotracheal tubes, which increase their risk for infection. NICU patients may develop abnormal flora that may be carried by personnel from one infant to another and may be resistant to usual drug therapy. Catheter-related bloodstream infections are a significant problem in NICUs. Signs of infection. In the newborn, early signs of infection are not as specific or obvious as those in the older infant or child. Instead, they tend to be subtle and could indicate other conditions. Temperature instability may occur. Only 50% of infected newborns have an axillary temperature above 37.8 Celsius, 100 degrees Fahrenheit. Respiratory problems are common, and changes may occur in feeding habits or behavior. The nurse may identify the early, subtle changes in behavior that could indicate sepsis. Experienced nurses may have a feeling that the infant is not doing well even before specific signs of infection are present. When this occurs, the nurse expands the assessment and watches carefully for the development of other signs. Early identification and treatment are important because infants can develop septic shock with little warning. Critical to remember: signs of sepsis in the newborn. General signs: temperature instability, usually low. Nurses or parents' feelings that the infant is not doing well. Rash. Respiratory signs: tachypnea, respiratory distress, nasal flaring, retractions and grunting. Apnea. Cardiovascular signs: color changes, cyanosis, pallor, mottling. Tachycardia, hypotension, decreased peripheral perfusion, edema. Gastrointestinal signs: decreased oral intake, vomiting, excessive gastric residuals, diarrhea, abdominal distension, hypoglycemia or hyperglycemia. Neurologic signs: decreased or increased muscle tone, lethargy, jitteriness, irritability, full fontanelle, high-pitched cry. Signs that may indicate advanced infection: jaundice, evidence of hemorrhage, petechiae, purpura, pulmonary bleeding. Anemia, enlarged liver and spleen, respiratory failure, shock, seizures. Nursing interventions. Preventing infection. Although it is not always possible to prevent infection, every effort should be made. Careful and frequent hand hygiene is the most important aspect of infection prevention. The nurse should practice and teach parents to perform good hand washing or to use hospital-provided hand disinfectants before and after touching any infant. Equipment should be disinfected according to hospital protocols. Meticulous sterile technique should be used during invasive procedures. Invasive procedures should be kept to the lowest number possible. The skin is delicate in the newborn, particularly so in preterm infants. Handling and trauma to the skin should be minimized as much as possible to prevent skin breakdown and infection. Precautions should be taken to avoid transmission of infection to other infants. This is accomplished with hand hygiene, separation of each infant's supplies, and standard precautions for infection control. These techniques should be conscientiously performed by all who come in contact with the infant. Parents should be taught about all infection control measures so that they can help protect their infants. Placing the infant in an incubator provides a physical separation between infected and well infants, similar to placing adults in isolation in private rooms. In addition, the nurse can observe the infant in an incubator more easily. Providing antibiotics. The nurse is responsible for obtaining or helping obtain specimens for laboratory analysis and checking that other tests ordered by the provider are completed. Laboratory tests will help determine the type and duration of antibiotics prescribed. Because the signs of infection are nonspecific and the disease can be fatal, physicians may order antibiotics before an actual diagnosis is made for infants who are at high risk or show early signs. Broad-spectrum IV antibiotics are given after samples for culture and sensitivity are taken and before the results are available. Continued antibiotic therapy is specific to organisms found on culture. The nurse should be knowledgeable about the antibiotics used and possible side effects. The nurse starts IV fluids and ensures that medications are administered as scheduled. If more than one antibiotic is ordered, the timing of administration should be coordinated to increase effectiveness. Antibiotics usually are continued for 10 to 14 days for sepsis and 21 days for meningitis. Providing other supportive care. Infants may be critically ill and need intensive nursing care. Care includes giving oxygen or other respiratory support as needed. Fluid balance maintenance, monitoring of vital signs, and hourly urine output measurements are important. IV or gavage feedings may be necessary if the infant is unable to take oral feedings. Infants with sepsis may have additional problems. They may be premature or have other transplacentally acquired infections. In addition, the nurse should be alert for signs of complications such as disseminated intravascular coagulopathy. Supporting parents. Nurses provide support to parents of newborns with sepsis and help them understand their infant's illness and treatment. The infant with sepsis often appears healthy at birth but suddenly becomes critically ill. Parents experience feelings of shock, fear, and disappointment when their apparently healthy newborn is suddenly moving to the NICU, or the preterm infant they thought was making good progress may suddenly develop a life threatening illness. Parents benefit from a chance to talk about their feelings with an understanding nurse who can explain the infant's treatment and care. Keeping the parents informed and involving them in care is essential.